Implementing a diabetic retinopathy program within a health system requires close coordination across three key areas of activity: administration, screening and grading, and clinical services. A team approach is therefore essential for the program to be efficient and effective. Public health specialists are also needed, ideally at the national or district level, to oversee the whole process. They ensure that population changes over time are monitored and appropriately addressed within the program. Let's consider the team roles in each of the three key areas. The administration team consists of a program manager, fail-safe officer, and administrators. Initially, these roles may overlap, but they are all essential for the safe running of a DR program. The program manager oversees the coordination and management of the screening and is responsible for it alongside the lead clinician. It is their responsibility to ensure that good standards are achieved and maintained throughout the program. Depending on the available resources, they'll be responsible for managing the screening of between 20 and 100,000 people with diabetes at one or several sites. The program manager's key activities include capacity planning to ensure appropriate availability of trained personnel, screeners and graders, and that the required equipment is in place and functioning. Ensuring the safe administration of the database, implementing the call and recall system so that the right people are called at the right time, monitoring any serious incidents or complaints about the program, monitoring screening data, and conducting quality assurance to ensure that the team is compliant with the training requirements of their roles. The administration staff are frontline team members and are often the central contact point between a DR program and people with diabetes. They conduct the call and recall invitations, make appointments, send reminder and results letters, and answer phone calls from the patients. Administrative staff need to be well trained on the workings of the program to coordinate responses to queries. For example, the administrator can answer a straightforward query about a patient's results letter, but they should pass on a request for an explanation of retinopathy status to one of the graders. The fail-safe officer has a key role within the administrative team. They maintain the database, tracking patient data and ensuring that there are no gaps in the system, such as lost referral letters or patients not attending screening or follow-up invitations. Screening and grading staff. Depending on the screening model, various combinations of healthcare personnel, healthcare assistants, dedicated screeners and optometrists can carry out the screening test. Their tasks include measuring visual acuities, administering mydriatic eye drops and then taking the fundus photographs, examining the fundus image. This is usually done by optometrists or trained screener graders, and providing the patient with supportive reminders on blood sugar control. In some models, a screener carries out all these tasks, but this can reduce their efficiency to screen many people each day. DR programs use screening teams in mobile or static locations, or a mix of both, depending on the setting. In each case, the goal is to use the most effective method to increase coverage of screening amongst the target population of people with diabetes. Some programs have the screener grader as the same person, whilst other programs separate them into two distinct roles. The advantage of the combined screener grader is the flexibility to move staff around as required. The advantage of separating the roles is to have all the graders in one office, where it's easier to monitor the quality of the grading and provide training. The overall output of the team also increases, and this can be the most suitable format for large populations. In telescreening models, the screener is often in a field setting and the grader is based at a static centre. The clinical staff attached to a DR program should include a clinical lead who is responsible for the patients within the program. They provide regular training for the screener graders and the administrative team and liaise regularly with the program manager to ensure that standards are being met. An ophthalmologist has to be available to review patients once they are referred for treatment. They can also provide slit lamp assessments for those patients not suitable for fundus photography. However, more often than not, this task is now undertaken by optometrists. Screening is getting the right care to the right people at the right time. Diabetic retinopathy screening should not just be about eyes. It's essential to maintain links with others involved in the care of people with diabetes, with diabetologists, diabetes specialist nurses and other such staff to provide health education and supportive management of diabetes, with local charities and patient groups to encourage people with diabetes to attend. Some screening programs have taken their clinics to places of worship, football grounds and locations closest to the population. To do this can require employing an engagement officer, and with counsellors to support patients to deal with the outcome of screening. It's a good idea to have monthly progress meetings or multidisciplinary training sessions to facilitate close coordination of a DR programme's activities across the clinical, administrative and screening teams and with the other groups.
So at our monthly team days, they're a really important day for the team to get together to celebrate good practice, but also to have an air and share session. They can talk about any issues they're having within screening or any of the venues that we go to. We also have the opportunity to invite guest speakers, so we might have someone come and talk to them about learning disabilities or diabetes itself, and we have some of the specialist nurses who come in and do that for us. Or it also gives the clinical leads the opportunity to talk about diabetic retinopathy and pathology involved in that. And we can also do group reviews of test and train exercises to improve practice. It's important that we do all get together because screening is quite an isolated thing when you're out in the community, and it's good to bring everyone together.
In summary, a trained screening team is essential to coordinate and manage the wide range of activities needed to support each patient through the screening process and its outcome. Each person with diabetes must be invited for the screening event at the right time and at an appropriate location and time, guided through an efficient and acceptable screening test and grading process, and educated with supportive information on diabetes and counselled on the outcome of the result. To be effective, this team approach needs to be carefully monitored across the locations and different roles and personnel that each patient encounters during the screening process.